gives us here is very, very nice. They make sure that the food is balanced diet food. After your food, they will give you fruit after meals. We feel at home. We feel like we are in our houses. The food we prepare at our houses, that's the same food we eat over here.
Me back Kolebu manye 2 weeks. So me ba asanya wo mpa. Me mpa aburu ma adwene meti ase so. Sane me ba mi ni sika nka me beto aduane. So me ba anapa tin anapa koko anapa raswata awia benku ene terapia ne nkuruma stew anwumre fufuo ana aponche.
And on behalf of myself, my colleague dietitians and nutritionists, I'd like to say a very big thank you to Kolebu. As Kolebu is celebrating its 100 years anniversary, I'd like to say a very big thank you for the opportunities, for the platform to be of great service to individuals and the country at large.
The level of care that I've received at Kolebu has helped me to manage my diabetes, and I'm very appreciative of it. So I thank Kolebu very much.
I know there are a lot of misconceptions about the nature and quality of services that are rendered here. But they should trust me when I say the best is only in Kolebu. And because of our level of experience.
Shall we please close our eyes for a word of prayer? Our Heavenly Father, we thank you for this evening. We pray that you be with us throughout this program. In Jesus' mighty name we've prayed. Amen.
Thank you, Gillette, for the prayer. So I will now hand over to the team from the Ops and Gynae department to give us yet another exciting webinar series for November.
Right. Welcome to today's department, obstetrics and gynecology, and to actually host this lecture or this webinar because it's we are going to topic. We are going to talk about an important, I normally say a magical organ in the human body, the uterus or the womb. The womb, because as we all know, the womb is a soil, a very fertile one, where human life actually begins, implanted, nurtured, and grown. This magical organ also sometimes are affected by some conditions, diseases. One of the commonest diseases that can affect the womb is fibroid. And today, we are excited to talk about the stories from the womb, fibroid stories. We are trying to dissect and melt all fibroids today before we leave. And I'm sure by the time we finish, all the stories about fibroid will be discussed. I'm sure we have all heard about stories where somebody has been pregnant for 2 years, even 3 years. They think they are pregnant, but it's all fibroid. We have also heard situations where even some take women to theater thinking they are going to deliver them. They actually deliver fibroids. Many from the womb to share with the public and also with our colleagues so that we can all learn from it. So today we have highly learned, experienced, young, and very enthusiastic consultant gynecologists who have prepared so well. They have the experience, they have done a lot of surgeries, they have a lot of stories when it comes to fibroid. And without wasting time, we have Dr. Eric Tete on my left. He is I have worked personally with him, and he's so much interested in fibroid. He has done so many fibroid surgeries, and he's so enthusiastic about fibroids. And then we have also Dr. Henry Kumi, who is also enthusiastic and very energetic. He loves the work, the gynecology work. And so today, I'm sure we are all waiting to hear what they have for us. I'll be moderating this program. My name is Professor Edubo Nsafo. I'm also a consultant gynecologist at the Kolebu Teaching Hospital. We work together hand in hand, and we all have a lot of extensive clinical experience when it comes to fibroids and its management. And today, before we start, I would like to give our panel the opportunity to give their own opening remarks so that we can set the ball rolling. Dr. Eric Tete.
Thank you, Prof. And I would like to welcome all of us, both viewers and listeners, to this wonderful webinar by Kolebu Teaching Hospital. So, Prof, as you said, stories from the womb. The womb, as we know, is where life begins, as you rightly said, and life ends, as we know, in the tomb. And so you'd imagine that stories that would come from such a magical organ will be exciting and good. But from where we sit as gynecologists, not, the stories or the experiences that most women that come to us are that good. And one of them, there are numerous stories from the womb, but one of them where we'll focus on today is the uterine fibroids. Okay, so the womb, if you want to know the womb or the uterus, as we gynecologists will refer to, is a reproductive organ. And from the picture we can see on the screen on the left, lies protected, within the bony pelvis. And anterior to this is the bladder, and then posterior to it is the rectum, and then the bowel. And the womb, every woman, when you make a fist, is the size of a normal womb. But this can enlarge or can become big. And most of the time, certain conditions would enlarge or make this womb big. Chief among them is pregnancy, like we all know. But the second is what we are going to talk about as uterine fibroids. And it leaves many women, anxious. Because if you are not pregnant and something as big as fibroids is occupying the womb, then what holds for you? So that will lead most of the women to come to us with those problems. And I'm sure that's what we are going to dissect and talk about. So this will be my opening remarks. Thank you.
Thank you, Dr. Kumi.
Thank you. Thank you very much for the introduction. And as Dr. Tete has talked about, today we are talking about a very important structure, which is the womb, and we'll be referring to it as the womb or the uterus. The stories are from our end as clinicians, and then there are also stories from patients' end as well. And in the course of our presentation, you would get to appreciate that it can present in various forms, and we'll get to that when we get to how it presents. However, as we all know, all those here and all those listening online know that life, all of us, at one point were housed in this magical structure. For me, as I look at the magical nature of it, I want us to think about how our current technology is. We are now living in a technologically advanced, world. However, this is how magical this structure is. In spite of the advances we've made in medicine, the womb is still the best incubator for the human fetus. No incubator can compare to this. So sometimes, even when there are problems, we still want the fetus to remain in this magical structure. And as Dr. Tete has said, unfortunately, sometimes this magical structure is plagued with some conditions. Some are cancers, some are not cancers. And today we are going to talk about it. And it's important we talk about this because this is something that is common with our women. Okay, and a lot of our women have misconception, myths, and all those things. And today we are hoping that before we leave here, people would appreciate how magical it is. And then when there are problems, to know that there are professionals who can help deal with them. Thank you.
Thank you. One lady once said that there is no other organ like the uterus, because uterus is only found in women and men don't have it. I'm sure if men had uterus, they would really brag of it. So if you look at the womb, can you let us know what the main function of the womb is? Then from there we can move quickly to the fibroid and probably other diseases. Maybe Dr. Tete, if you can really tell us what the function of the womb, the main function, where you can also relate to the menses and the significance of it. Thank you.
Thank you. So when we take the womb, so it has layers, okay? So the very inside of the womb, which is the cavity, we refer to it as the endometrium or the cavity. And then, next to that is the muscle bulk of the womb, which is the myometrium. And then at the surface is the serosa, or the covering of the womb. And as I mentioned, it's part of the reproductive system. So it will start from the outside, the vulva, through the vagina, the cervix, the uterus or the womb, the fallopian tubes, and then the ovaries. That form, the reproductive system of the woman. So the womb main function is for menstruation. That is one. Okay, so for every woman, you know that cyclically, and I remember in our basic sciences, Prof. Engman once said that, the menses is like a womb which has been prepared in anticipation of a pregnancy and gets disappointed. So it's like a womb crying. So that's he referred to as the menses. So principal function or primary function is the menstruation. And cyclically, every woman goes through that cycle. So where the womb gets prepared in anticipation of a pregnancy, once a pregnancy doesn't come in or a baby doesn't come to lie in, it means that the inside might be shed, which comes as the flow every month. And then the other thing is about its ability to carry a pregnancy once the pregnancy happens. So these are the two main functions of the womb for its reproductive, function. Yes. So that would, I don't know if Dr. Kumi wants to add something else.
No, I think that's basically it. Is the main reproductive structure that we have, and it houses the fetus, as I talked about, very magical. All the technologically advanced countries are around. We've all heard about NICU and all that. All they are trying to do is to emulate the conditions in this magical structure. So yes, as he's talked about, the womb basically helps, house the fetus all the way to, 9 months, and then prepares the baby for extrauterine life. So that's the main thing, but as we've talked about, unfortunately, sometimes it is plagued with problems, and then we have to go in and, as it were, repair and work on it.
So thank you for telling us about the womb, what it is, and the function. But having said that, so how does it get disease? What diseases can affect it? We know fibroid is the commonest one that can affect the womb, but it looks like the other ones. Before, I would like you to just mention one or two other conditions before we even move to the fibroid, where we talk about the locations and all that. So are there any other diseases that can affect the womb apart from fibroids?
Yes, so as you...
All right.
Yeah. As you rightly said, the womb is often plagued by common conditions such as fibroids, and it's very common. That's why we hear about it a lot. But there are other conditions that can affect it. You can have situations where, and as we'll get to know fibroid is not a cancer, but obviously the womb can be affected by cancer. And cancer can affect the lining. Dr. Tete talked about the fact that it has an inner lining, it has a middle portion and an outer portion. The inner lining can be affected by cancer. And in our medical jargons, we will say the endometrial cancer. Of course, we've all heard that the womb has a neck, okay, which we describe as the cervix. That cervix can also be affected by cancer, which is one of the unfortunate cancers that, although are preventable, is quite common in our part of the world. There are a host of other conditions, adenomyosis, that one is not the cancer, but it can also present almost similar to a fibroid, and oftentimes it's even mistaken for fibroid. So that one too can occur. Of course, there are other conditions that actually people are born with, okay, where people are born with double, uteruses. It's also an abnormality. Some are born with, Dr. Tete mentioned the fact that the uterus is supposed to be similar to maybe the fist, but some people can be born with a fibroid that is almost rudimentary, very tiny, and really not fit for purpose. So there are a host of other conditions that can affect it. Some congenital, some born with, some acquired in the course of one's reproductive life.
Thank you very much. So now let's move to why we are here. Dr. Tete, do you want to tell us what fibroid? Fibroid, a lot of us have heard about fibroid. When you walk in town, people are asking, like every woman you see complains of fibroid. Is it that common? And what is it?
Yeah, thank you, Prof. So, yes, as you rightly said, fibroid gets a lot of women both anxious and worried. And most women, once they either are told that they have fibroids, the first thing they do is to try and see a clinician or somebody to try and know why that is happening to them. So basically, fibroids are the commonest pelvic tumors, benign tumors that we have. If we say benign, means they are non-cancerous pelvic tumors in women. And for us, blacks, we tend to have a higher risk of getting fibroids as opposed to the whites or the Caucasians. And fibroids, the cause, as we sit here now, it's unknown. Just that we know that its growth and development is hastened or is helped by reproductive hormones, especially estrogen and then progesterone. Okay, so you would have it that how it originates. So normally you have a muscle cell, a smooth cell, okay, being transformed or is changed from its nature to a more fibrous consistency. That's how the name came up in the first place. So you have a transformation of a smooth muscle cell that will now undergo a change or transformation to form, a fibrous consistency, this whole tumor or benign lesion. Okay, and as I said, nothing that the exact trigger, we don't know. But we know that female reproductive hormones, especially estrogen and progesterone, would help and maintain its growth. So that's what I would say for now. I'm sure Dr. Kumi will add something and then.
Yes, thank you. And I think this is one of the, common questions that are on the minds of, our clients out there. Why do I have it? Why is it that this person doesn't have it and I have it? So, as Dr. Tete said, the exact cause is unknown. You see, unlike I talked about the fact that the cervix can be affected by cervical cancer. We know the cause, that we know this is caused by this virus. But for uterine fibroids, we don't know the exact cause. But as he said, it is rare to have it in a prepubertal woman, as in somebody who is 5 years, 6 years having fibroid. It's almost unheard of. And in medicine, we never say never, but almost unheard of. Again, we know that when women become menopausal, if they didn't have fibroids before, it is rare for them to now develop fibroids in those years. And that is where it's quite clear that the growth of the fibroids is influenced by the female hormones that he's talked about. But we all know, all the females have it, but not all of them develop it. So the exact cause is not known, but we know that its growth is really fired up by these hormones. So as we talk about this, a lot of work has been done. People trying to find out what causes these things. And yes, there are some genetic, mutations that have been, looked into, because as Dr. Tete said, it's the muscle of the womb, as you can see on your screen. It's a thick muscle, and we call it a smooth muscle. And each fibroid you see is from a single muscle cell that, acquires some changes and then, grows more than it should. It's been known that although the whole womb responds to these hormones, the muscle cell that would eventually lead to fibroids has so many receptors. So it's like they over-respond. But why they over-respond, why they have more receptors, nobody knows. So we don't know the exact etiology, but we know what drives its growth. So I think that's...
All right, so some time ago I had a family that there were 3 ladies in the family, siblings, and all of them had fibroids. And and they had all had treatment like surgery for it, and then I realized when I asked, it looks like the mother had also had surgeries, and so all of them actually delivered through surgery. And so, talking about the genetic aspect, do you have other factors that can be related to fibroid development? And remember, Dr. Tete mentioned that it's not also cancerous. So, are there some factors that predispose some families to? Because the patient I talked about, I did fibroid surgery for her, and after about 6 years, I had to do again. And I think probably genetic. Do you want to comment on that?
Yes. So as I said, a lot of studies have been done, and this is purely because, you see, this condition is a major public health importance, because as we go on and talk about the symptoms, we know that it affects a lot of women. Some have to, it affects their quality of life, their work is impacted, and so a lot of work has gone into trying to find out this thing. And although we don't know the exact cause, the risk factors are well known. So, like you rightly said, it may run in families. Okay, and as I talked about, they found out there are some genetic, abnormalities in the cells that eventually develop fibroids. So, some of the studies that have been done have actually been done in twins. And they found out that if you have identical twins, if one has it, most likely the other will have it. And we know that the identical twins are those who they have the same genetic makeup. But if you have non-identical, what we call the fraternal, it doesn't always work that way. So if you take 2 individuals, one with a strong family history, one without, you know that the one with the family history has a higher chance of happening. And there are some chromosomal abnormalities that may run in these families that may lead to that. So definitely there are more risk factors, and I'm sure Dr. Tete will allude to more of the other risk factors.
Even before Dr. Tete, I'm sure viewers will want to know something about food. So think about food.
Yes.
As you talk about the others, I want to, because it's something that I'm sure others, we can't talk and ignore it.
So Prof, you are right. I mean, in our line of work, I mean, sometimes you sit in the consulting room, a woman comes to you probably with a scan or having gone through a screening process, which may have picked up a fibroid. And the first question they ask you, Doc, don't you think it's something I'm eating that is making me develop this? So I'm sure in the minds of most of our women who come, they think that probably it's something they ate because they don't understand. And as you rightly said, some too the mother didn't have, the aunties don't have, but they have. See? So yes, so for food, when you look at the studies, and this is not conclusive though, but it's been shown that those who have significant intake of red meat, okay, have a higher chance. If I say higher, it doesn't mean that when you go consuming meat means that you develop fibroids by all means, no. So those who have significant consumption of red meat have been shown to be associated with uterine fibroids. Aside that, none other, like maybe vegetables or eating of anything, has been really associated with development of uterine fibroids.
Good, thank you. So I'm sure when we finish, People will be calling you to find out whether they should stop eating red meat and all that. And so you have to prepare for that.
Yes.
All right. So, so having talked about that, how do we know that? I'm sure somebody will know. Some people haven't gone to hospital. Some women haven't really gone to check whether they have fibroids or not. How would they know? If somebody calls you now, you're a gynecologist, been working, they want you to tell them how they will know that they have fibroids. Is it always loud? I mean, is it always symptomatic?
Yeah, but before I come to that, some of other risk factors that probably others want to know is that if you stayed nulliparous for a long time, okay, it has been associated with development of fibroids. Again,
that means, you mean nulliparous
means someone who has not having given birth or having had a child before.
All right.
And then sometimes as a woman, if your menses come too early, so early menarche and then late menopause, this is because you see you have a longer period of the womb being subjected to those reproductive organs, hormones we talked about. So then your risk tend to be higher. So that would also be one of the... For fibroids, most of the time, it's asymptomatic. Majority of cases is asymptomatic. So a woman may have fibroids walking around until maybe a screening or some test is done on her. Probably she went somewhere to do something asymptomatic. So a screening tool may pick up a fibroid. Again, the other, so that's a scan. So normally you would have a scan done to pick. Other screening modalities are there, like other tools that we can use to diagnose fibroids. Like a woman who goes in to have a procedure, like let's say a hysteroscopy. So hysteroscopy is like using, like a camera, okay, to look into the inside lining of the womb. Sometimes there are fibroids that are there that can be picked up. So that's one way too we can pick up. And then laparoscopy. So laparoscopy, again, you use a camera, you want to look into the woman's abdomen, okay? And sometimes you can find those fibroids. So these are some of the tools we can diagnose. Aside the woman coming with the history and then our clinical examination, which sometimes too we can pick up.
Okay,
when
so
we examine these women.
Yeah, I think Dr. Kumi will add to it, but she's at home.
Yeah.
She wants to know, so as I'm there, are there things that I have to look out for? Maybe Dr. Kumi, you can, am I, my menses or anything?
Yes, so Prof, just pardon me a bit, let me just go back about the risk factors. So as we are talking about the risk factors, let us know, as Dr. Tete said, there are also protective factors. So people who have, given birth, or who have gotten pregnant and carried to, 9 months and all are protected. And it is said that one of the other thing is also, he talked about the pregnancy, but that interval has also been shown to be a major factor where the interval from one pregnancy to the other is wider, okay? So over 2 years interval is said to also increase the risk of fibroid as well. And a host of other things. People have thought about the fact that, increased physical activity is protective, as in if you have an active lifestyle, it's protective. Even smoking is said to be protective. However, this is not to advocate that go smoke just to reduce your risk. But there are a lot. And on the dietary bit, as he said, these are not conclusive. So we have to be careful in taking about, like he said, significant consumption. And I think he clearly stated significant consumption of red meat is really known to put women at risk. And why, maybe it will come, why the fact that, you are black, there are a whole lot of undertones why the black people are at an increased risk. So these are things that we have to think about. People who have used some form of contraception, the intrauterine device may have a reduced risk and all that. So there are a whole lot of things that the individual coming, her history alone will help us to appreciate.
Okay, so now can you go on to talk about somebody, a woman who is listening to us, yes, and wants to know some of the things, yes.
Yes, I think this is really important to know that most fibroids are silent. And you know, we've had a lot of patients. You sit in the consulting room, patient comes, and you are able to diagnose her with fibroid. And we'll talk about how we will diagnose it, but the question is now how they would know, or are there things they will know. And interestingly, some of the stories are that, why did I develop it? You know, or why didn't I even see it early? And sometimes the reassuring thing to let them know is that there are many people walking about among your peers, among your friends who have it. So the truth is that most of the time they're silent. However, what makes a lot of women find out is, in addition to what Dr. Tete has said, is either because it is giving them symptoms like heavy bleeding, prolonged bleeding. For some people, it is because their tummy has become big and a partner has pointed it out to them. Okay, some people realize that they are urinating now more frequently than normal. So this will bring them to the hospital. But as Dr. Tete says, some people, they are normal. She got pregnant, and as part of early pregnancy, she is going to the hospital. Doctor sees her, assesses, does her scan, find out, you even have fibroid. This is somebody who didn't know. And the majority of our clients are in that, where they have it, but they don't know. And it is okay if you don't know it. It's okay. Because if it's not giving you problems, as we'll talk about, we let it be. But most people have it, but they don't know. In fact, in our clinic here, for instance, quite a number of the patients we see, in fact, both at our clinics on admission, are purely because of fibroid. But these are patients who have fibroid that are giving them problems. But for a woman who is sitting at home, if she doesn't have any of the things like abnormal bleeding, prolonged menstrual bleeding, or she hasn't seen that her tummy has become big, most of them will not know until something takes them to the hospital to do a scan or so. And as I talk about the abdominal, the lower part of the abdomen becoming big, some people, after an educational session like this, will now wonder. And some people have come with that thing and realize that it's just abdominal fat. So whatever the patient is experiencing, it is better they come, then we would confirm it for them. But most of the time, it's a silent disease.
Good. Okay, Prof, yes. I just wanted to add. So one time I was in the consulting room and a patient came in. So what actually brought her was that, and if you look at the pictures I showed, where the womb is located, it's between the bladder and the rectum. So apparently she had a fibroid that had caused, kinking of the bladder neck. So that will cause an acute retention, and that's how she presented. So you can have some presentations like this, which later we found out that, it was the fibroid that, was not making her unable to urinate. So there are stories like that when it comes to the presentation.
Good. So one day there was a patient who complained. In fact, we didn't know, but she had been having severe pain during her menses. And she thought it's one of those, but they can keep pain. And she has kept the pain for a long time and thought that it's the normal menstrual cycle pain or menstrual pain. And when she came, somebody brought her, we did a scan and we listened, realized that she had a fibroid that was probably causing the pain. We thought that was. So I want you to let us know how this situation also fits in. Fibroid causing pain, and sometimes when she's not even having her menses, she's having pain. And even some have complained that during coital activity, they have pain. Is this something that people can also complain of?
Yes, Prof, that's true. Pain is one of the presentations, as Dr. Kumi was saying. So mainly you have 4 broad ways women can present. So you have those who come with abnormal bleeding, either heavy or prolonged bleeding, and those who come with pain. Okay, and then those who will come with bulk symptoms, so they will cause either obstruction of some sort, whether they can't urinate as of all. Some may even come with constipated. Okay, and the last bit is about the reproductive dysfunction. Okay, where you talk about people not being able to get pregnant and all that. All can can come as presentations of fibroids. Now for the pain, most of the time, like the bleeding, okay, the size the location of the fibroid most times determine its nature when it comes to pain. So you have, for instance, those who have it, we call something we call the submucous, or those who have endometrial polyps, okay? Because it is a foreign body sort of in the cavity of the womb, now the womb tries to expel or tries to push that which is foreign to it in the womb out. And by the sheer nature of it trying to expel or push that out causes so much excruciating pain for women. And most times at the emergency, when I was a resident at the emergency, one woman came in. You know, she came in with so much pain and bleeding. And when we took the history and then we examined, we saw that there was a fiber that was coming from the lining of the womb through the cervix outside. That was causing her so much pain and bleeding. And luckily for her, once we took her in, we gave her some pain medications, and then we tried to, twist the fibroid. The bleeding just stopped immediately, and the pain just vanished. So these can cause pain. And we also know that, as Dr. Kumi was talking and saying, the fibroids themselves have the propensity to produce prostaglandins. And these ones are noted to cause a lot of pain, especially during menses, okay, of most women. And again, based on the location, for those ones that are posterior to the uterus, especially that goes, you have some of them that are serosal, some are hanging just by a stalk. They can go into the pouch of Douglas and then be there and can cause so much pain to the woman during sex, which will cause the dyspareunia. So women can come in that nowadays you realize that if she's having, intimacy with the husband, she feels so much pain. And that can also be a cause of uterine fibroids.
So just, in addition to the pain, as they can see on the screen, these are tumors arising from this smooth marrow. And as it grows, it feeds. We all know that it is overgrowing. So soon enough, the blood vessels that are feeding it become inadequate. So then it starts undergoing some changes. And I'm sure at some point we may talk about it. It may start undergoing some changes. And the changes are because the thing is growing, the blood vessels feeding it is not, commensurate with it, and therefore it undergoes some changes, some ischemic changes, and we call them degeneration. And as these changes are happening, they lead to pain as well. So they may have, like you said, sometimes the pain is even not related to the menses, but may be exaggerated during the menses. But in addition to all that he said, those changes in the womb as the fibroids grow may also lead to pain. And of course, sometimes, depending on it may twist as well. Sometimes you have some, I think Dr. Tete talked about it, it may twist, and that may also lead to pain. And also the degeneration is a key cause of pain, especially even when people get pregnant and they have fibroids. It becomes a major issue. But we know that most of the time pain is not really one of the things. But when they have pain, in addition to the issue of infection and all the other things, degeneration is a major cause of pain for our women. But in all these things, there are ways of dealing with them. Thank you.
Good. So I think Dr. Teacher was trying to talk about the different types, where you said some will be hanging in the vagina. That's the prolapse one. And then the submucous, the one that is also hanging within the womb, the cavity of the womb, and also within the muzzle, and then the others that are on the surface, either at the back or in front, and maybe even be very far from the womb itself. And so among all this, which one is the most dangerous? Can you really say that this is the most dangerous, or causing more symptoms?
So
or
in terms of
like that?
bleeding, or the symptoms that we talked
pain,
about,
or any other symptom.
Okay, so when it comes to bleeding, the one that is not preferred, I wouldn't say that it will lead to more bleeding, is the one that is submucous. Yeah. Okay, so in the picture, we can see
The one that is hanging?
Yes, the one that's hanging, and then the one that is within. So the submucous ones would, and it's for obvious reasons, because you see, during the menses, the lining of the womb is shed. Okay, so once the lining of the womb is shed, you would have exposed vessels. Okay, and then because these submucous would more or less increase the surface area of the lining of the womb, it will lead to more bleeding. Again, by the presence of other nodules or other fibroid tumors in the muscle, the muscle is supposed to contract and retract so that it blocks those blood vessels that, bleeds to have the woman see her menstrual flow. So that will disrupt the architecture a bit. So then you have poor contractility, and that can also worsen the bleeding. So those ones, when it comes to bleeding, are notorious for that. Okay, and then when it comes to those that are pedunculated, most of the time, those are the ones that don't even cause the woman any sort of pain, because those ones, as you see, sometimes have a stalk. Okay, and it's just linked to the uterus or the womb by that. So those ones will not cause any problem. So those are the ones I will talk about. So the submucous ones and the ones within, okay, like the pedunculated submucous ones, are very notorious for bleeding, which most of the time our women present with.
Yes, so in addition, it's important to appreciate, I think as can be seen on the screen, there are different types. Dr. Tete has talked about it. The womb, as you see, it has 3 layers. So you have some of the fibroids on the surface, some are in the middle part, which is the thick muscle, and some are, within the cavity where, baby also lies. And it is interesting to note that a minority of fibroids are actually the submucous type, the one in the womb. It is said about 5% to maximum 10% of all fibroids are the ones found inside the cavity. But interestingly, like he said, they're troublesome clinically. Because remember what we talked about. Most patients have it when they don't know. What brings them to the hospital is that they are having abnormal bleeding, either heavy or prolonged. And oftentimes it is these submucosa ones, the ones inside the womb, that lead to these things. And it's also important to recognize that they don't need to be big. They can be small, but the mere fact that they are located in this lining of the womb, as Dr. Tete has mentioned, this is where it's, every month there is shedding. So the fact that they are in there is the problem. So you can have bigger fibroids on the surface. Most of the time they don't cause anything. But you may have this tiny one in that area, and clinically it is the most troublesome, and it will bring a patient. So this patient will come, they are not having any abdominal distension or anything, but they will be having symptoms. So definitely the troublesome ones are the submucosa ones.
All right, so on the picture that we see, I'm sure we have heard about these stories where people think that once you have fibroid, it's difficult to get pregnant. But as I see it, I think it's the same place as Dr. Kusese said, this is where babies are kept. So is it true that really fibroid can cause women not to get pregnant? From what you are saying and even what we see, I think this one, we want to hear your side of the story from your side, and then Dr. Kumi will tell us what his experience is on about this.
Yes, so thank you, Prof. And I think this is one of the many, concerns, as it were, when most of our women come in and they have fibroids. The first thing they come and they ask you is that, Doc, will I be able to get pregnant? Can I make babies? What are my chances like? Because the notion or the perception is that once you have fibroids, it will be difficult for you as a woman to get pregnant, let alone carry and then give birth. But I will answer by saying that fibroids are not a cause of infertility, although it has been shown that it's associated, okay, and I would explain. So the mere fact that you have fibroids doesn't mean that you cannot give birth or you cannot get pregnant. And I would back this by saying that most obstetricians, most gynecologists have had patients, and in fact, most doctors have had patients who have had fibroids, and yet have been able to get pregnant. So that alone tells us that if you are told that you have fibroid, it doesn't mean that you cannot get pregnant. That said, depending on the location of some of these fibroids and what these fibroids do to the womb, sometimes may delay or may be a consequence of why a woman's pregnancy is delaying. And I would explain. So when we look at the fibroids, again from the picture, you see that we said that some can be within the muscle of the womb. Some can be within, at the lining, which is the endometrium. And so for those ones that are especially within the lining where the baby will go and develop, or go and lie and develop, which we call the submucous, have been known to be notorious for women having miscarriages. So a woman, gets sperm is able to fertilize an egg, let me say, the embryo moves and then gets to the cavity, wanting to implant. But if there's a fibroid at the location where the pregnancy or the embryo wants to implant, that can cause the woman to miscarry. And we've had several women who have those peculiar kinds of situations, have, recurrent miscarriages. And fibroids have been known to do that. Okay? Once that is identified and sorted, those women are able to get pregnant. Okay? Now, again, if the fibroids are located at places, especially, where the sperm would have to travel, it has to go through the tube. We know that the tube is where fertilization occurs. So if you have a fibroid that is very stubborn and it is blocking the ostia is the opening into the tube, and doesn't allow a sperm to move, definitely that would affect a woman's ability or chances of getting pregnant. So then that would mean that that woman will not get pregnant unless that fibroid located there is removed. Again, studies have shown that the fibroids will make the architecture, it will change the architecture of the womb, such that it makes the womb so big. And we've seen, I'm sure Dr. Wimi will bear with me, we've seen women who have come with huge fibroids. Some like, a woman who's like, let's say, 4, 5 months, 6 months pregnant. So, and those fibroids would change or would increase the travel time of how a sperm will move to go and fertilize. And those things would all affect a woman's chances of getting pregnant. So those are some of the things that may be said about
Great.
this. I don't know
Dr.
if
Kumi
will add.
Yes, so just to take off from it's about 9 months womb.
Yes.
The womb is filling, the fibroid is filling the whole abdomen. And as he said, this sperm will travel and get tired before it even gets to the to the egg. So that is it. But I think of course, on that same score, if you have the fibroid at the mouth of the womb, it may, lead to a physical and mechanical obstruction, also affecting sperm travel and all that. But I think the first thing he said is very important, and our listeners should appreciate this, that there are several reasons why a woman may have inability to conceive. And it may be male factor, it may not just be the woman, it may be a male factor problem. And the female factor, multiple. They may have it as a tuber problem, So the issue is that when there is inability to conceive, the first thing is not fibroid. There is an association like he's described, looking at the location. However, if a woman is unable to conceive, it is better we start looking at other things. If we've explored all others and are not able to find the cause, we can now decide to look at the fibroid. But like he said, we have countless women who are pregnant and they have coexisting fibroid. In fact, about 5 years ago, we had a patient who actually had very huge fibroid, about 6 months, like somebody who is 6 months pregnant. And she had come through, we're preparing her to do surgery to remove her fibroid. And of course, she had also been married for some time, not able to conceive. And you see, when there is inability to conceive, let's remember, sometimes it is because they are not even having enough intercourse. Okay, and you rightly talked about the pain. They are not having enough intercourse because she was always having pain. We had prepared this patient. We had actually given her a date just about 3 weeks to the date, she came to us that she has tested positive for pregnancy. And she was able to carry the pregnancy to 9 months and deliver. So fibroids in themselves are not the cause. When you have a patient who has inability to conceive, we look at other things. But you see, as we are talking about these stories, it's also easy for clinicians to be, investigating the patient for infertility. One of the initial things they do is ultrasound scan. As soon as they see fibroids, then everything starts to say, maybe that's the cause. But that is not. So we have to look at other things and appreciate the fact that we have so many women who have fibroids and they get pregnant. But if we look at the other, we investigate and find out that we can't find the apparent cause, then we can really look at the fibroid. Because if that is not done, you will go ahead, treat the fibroids, and the infertility will still be there. So it's important we put it in the right context that yes, there's an association, but there are countless reasons why a woman may not be able to conceive.
Thank you. I think you've dealt with this question very comprehensively. But let me remind us that there are a lot of people online, Facebook, also trying to watch. We have Jane Sharp from the Netherlands. He's so excited about the program and he's showing a lot of interest. We also have Evans Kintor from Sefio, so he's also very active and listening and watching at the same time. We have Gertrude Kintor as well, also watching. And we have Dr. Sroda Agudogu. I know her personally. I think she's in the US. She's a gynecologist in the US who is also watching, and many other people also watching. And at this point, I think we should talk about one or two more questions, and then we can probably open the floor and look at other questions, especially from maybe the people online and also on YouTube. So maybe we should have a short break now, and then we can rest, fix some water, and take some other things, and then we can move on. So I think we should take a break now, and then we can have some musical interlude. Yeah. Thank you. We'll be right back. Thank you.
Situation be a me komu na ha adwen kakra. Me benya fibroid. Na me mpese mejiedi because me da warfarin so. Nti na me nim say warfarin because of warfarin no fibroid to me here.
For the fibroid cases that we see, the main treatment we offer here is basically surgery.
So the services that we render here, because we have all the professionals here, every referral that is above those at the district, the regional, they all come here.
Yeah, fifi mu ano na yampa se menya fibroid. E na me ba me doctor ewo cardio o refer me e ma me ba gynae ha. Ti gynae for so start hwe me. E ko ba say meye surgery, omo be ye me surgery foforo. Na me say we die. Man kan kire obi aba me kan o me tirim se me mba. E na me sign ko fi labs foforo ne nioma bebre. Ba ni nyina echi no ya surgery na mama ya boni bi antome me nam ha boni bi antome na menim se ade ne ye kese pa nti na menim se ehu nti mintumi nye but nyankopon adom erade fa doctors ne so edije me.
If the woman has fibroid and it's not causing any problem, we leave it alone. If the fibroid is causing a lot of bleeding, such that they have to be transfused and all that, we need to do surgery and remove them. So we have two fibroid surgeries we do basically. What we call a myomectomy and then hysterectomy. Myomectomy is for those who have not yet completed their families. Maybe the younger people, we just go to theater and remove the fibroid singly, and then we repair the womb. For those who have completed their families, we prefer to remove the whole womb together with the fibroids. That's what we call hysterectomy. So for the treatment for fibroid, the mainstay, I'll say, is surgery. Those that have no symptoms at all, we just reassure them. It's not every fibroid that comes down, we quickly go and do surgery. No, a lot of them that are not causing any problem, we just reassure the clients that they should, we do what we call watchful waiting. It's when they are causing symptoms that we should go and do surgery for.
First, no, you're bokole good na me yam sheshemi. Yes, ebi mu say enye kolebu nye ko mu suro kolebu ni ade. Nti na me so ehu kakra wo me mu. But ni nyina echi no me baaye no. Be hu say ente sa na fibroid no krapo. Enhye da nye hu ti sese ne na kane no medwen no.
Mondays, if you come to this unit, the whole place is full because of the special care we are giving and the outcome that is coming out.
We need to really educate everybody to be coming for screening for cervical cancer so that we can pick this thing early. In fact, the cost of treatment is so small when we pick it early, but the cost of treatment is so huge if we pick it late. And even that, the treatment is not really, most of our people come with advanced cancers, what we call stage 3, stage 4. We don't do much. They have to go for radiotherapy, chemotherapy, and these things are expensive. We don't even have the setup. We have, in this country, how many centers do we have for radiotherapy, chemo? It's just like 3. Kolebu, Kumasi, and then there's a private one. If these things are picked very early, surgery for it is simple. And then so the way forward is to age from about 30, 40, you must have done a pap smear at least. So that if we are picking these pre-malignant lesions, we can treat it. Because cervical cancer really gives you adequate opportunity to treat early.
Always ready to accept patients and take good care of. We just add value to their care, the quality of life, by giving them all the nursing care and the medical attentions that they receive. So we are doing a lot to help the country. On behalf of myself and my team, we say Aiko, thank you, Kolebu.
Kolebu, mesdames ase.
Thank you, Kolebu.
Emre kakra etwemu yi. Situation bi a me komu no na eha adwen kakra. Me benya fibroid. Na me mpese mejiedi because me da warfarin so. Nti na me nim say warfarin, because of warfarin no fibroid into me hear me.
For the fibroid cases that we see, the main treatment we offer here is basically surgery.
So the services that we render here, because we have all the professionals here, every referral that is above those at the district, the regional, they all come here.
Ye hwehwe mu ano na ya mpa se menya fibroid na me ba me doctor awo cardio o refer me e ma me ba gynae ha ti gynae for so start hwe me e ko ba se meye surgery omo be ye me surgery foforo na me se we die man kan chiro obi aba me kan o mitim se me mba na me sign ko fi me ko she mu sa but edu baby no na me ntumi biu na me ba me san ba biu no na me san ye labs foforo ne neoma bebre ba ni nyina echi no ya ye surgery na ma me aboni bi antome me nam ha aboni bi antome na me nim se ade ne ye kese pa nti na me nim se ehu nti me ntumi nye but nyankopon adom erade fa doctors ne so edi jeme.
If the woman has fibroid and it's not causing any problem, we leave it alone. If the fibroid is causing a lot of bleeding, such that they have to be transfused and all that, we need to do surgery and remove the So we have 2 fibroid surgeries we do basically. What we call the myomectomy and then hysterectomy. Myomectomy is for those who have not yet completed their families. Maybe the younger people, we just go to theater and remove the fibroids singly, and then we repair the womb. For those who have completed their families, we prefer to remove the whole womb together with the fibroids. That's what we call hysterectomy. So for the treatment for fibroid, the mainstay, I would say, is surgery. Those that have no symptoms at all, we just reassure them. It's not every fibroid that comes down, we quickly go and do surgery. No, a lot of them that are not causing any problem, we just reassure the clients that they should, we do what we call watchful waiting. It's when they are causing symptoms that we should go and do surgery for.
First, no, you're good in na me yam shesheme. Kolegu nye ko musu kolegu ni ade. Nti na me so ehu kakra wo me mu. But ni nyina echi no me baaye no. Me hu se ente sa na fibroid no krapo. Enhyeda nye hu ti sesene na kane no medwen no.
The whole place is full because of the special care we are giving and the outcome that is coming out.
We need to really educate everybody to be coming for screening for cervical cancer so that we can pick this thing early. But the cost of treatment is so small when we pick it early. But the cost of treatment is so huge if we pick it late. And even that, the treatment is not really, I mean, most of our people come with advanced cancers, what we call stage 3, stage 4. We don't do much. We have to go for radiotherapy.
Who have wide and varied experiences with the management of fibroid. And today we have, in the first section, we have discussed what the womb is, what diseases can affect the womb, fibroid, and the different types of fibroids and how they present. I mean, how they cause problems to women. And at this point, we want to take some comments from the first half of our panel. So Dr. Kumi, do you have something to say before we even move to the second section? And then after that, Dr. Tete can also come in, and then we can move on to the second section. Thank you.
Right. So thank you very much. So as we proceed, just a recap that we've gone through what fibroids are, how they present. But as we talk about these stories, let's remember that we said that most of them are silent. But we know that some will present because it is causing them abnormal bleeding that is either prolonged or heavy, or it is causing them pressure symptoms. Dr. Tete talked about it. And you know, this is something we see from time to time. And as we talk about these things, I want us to know that they can also present in very weird ways. So we've had patients presenting to Kolebu with acute retention. And what we mean is that she's unable to pass urine. And this patient ends up not actually at the gynecology emergency, but at the urology, and they find out that the reason why she's unable to pass urine is because the fibroid is present on the bladder. So somebody may present not with, so this person had a big fibroid, but it wasn't causing any heavy bleeding also, but just her inability to pass urine. Again, we've had patients who have actually not having abnormal bleeding, but just collapsed at home. They presented and we realized that there was a lot of blood in the abdomen, only to find out that, you know, and initially most gynecologists would think, this is an ectopic pregnancy. We go in and find out that it is part of the fibroid that had broken off, or a blood vessel that was there that had broken off. So it can be very weird. We've also had situations where it was during pregnancy that things showed up, and our team, for instance, has had a very interesting story of a patient who came all the way from some part in the Volta region, where as early as 20 weeks of her pregnancy, she actually started experiencing symptoms that looked like a cancer. She was losing weight, she was, unable to eat, and everybody thought this woman had cancer of the ovary. Of course, we investigated her pregnancy was intact, but unfortunately she had fibroids that were growing aggressively, during the pregnancy. Of course, we found all these things out because we were forced to go and operate on her. We operated on her because at some point she couldn't even breathe. We went in and realized that this was fibroid that had undergone changes that were preventing her from having, just normal diet. So the point is that when we have patients just presenting with the usual thing, heavy bleeding, prolonged bleeding, but they may present in varied ways as well. And we, because we sit at the teaching hospital, we see all sort of things. And we know that there may be doctors elsewhere too. They see all the presentations we talked about, but we oftentimes at the receiving see a lot of not so straightforward the presentation, but they all exist and they are all fibroids. Okay.
Yeah, so Prof, as recap also, we just want us to all know that fibroids are common, especially in women, and in women at any age group can develop fibroids. But we say that it's more common in women who are 30 years and beyond. Because of what we know as reproductive hormones that aid in the growth of fibroids, you would expect that a woman who is nearing her menopausal age will not develop fibroid. Okay? Then we say that fibroids tend to regress, especially when the woman nears her menopause. Okay? And then we also said that fibroids, based on their locations, okay, would give problems to women. And we said that notorious for bleeding, no matter the size, is those ones that are found in the submucous of submucosal fibroids. Those ones, even they are small, can let a woman bleed a lot. Again, we've seen that fibroids are common in we black women. So in my consulting room, when a woman comes to me and they are worried because a scan or somebody has told them that they have fibroids, I tell them that, look, if we go out there, we pick up 10 women and we screen, it's likely that 7 out of the 10 may have fibroids. And in fact, this is indeed supported by radiological findings, and even the pathologist will tell you that although we say that the incidence is about 20 to 30%, in the pathology it's about 70 to 80%. So it's something that is common. So I tell them that, look, you don't have to be afraid, but it's something common because you are black or in black women. Again, the fact that you have fibroids, we've noted here from the first section, that doesn't mean that you can't get pregnant, or doesn't mean that it's the one that is preventing you. As Dr. Kumi rightly said, there are numerous causes of why a woman cannot get pregnant. Okay, so if those ones are investigated and ruled out, and there's nothing to show, then we can, focus on the location of the fibroid being maybe a cause. But then we've seen women who have had fibroids and are able to get pregnant and carry those pregnancies to full term. So that's what I would say, Prof.
Good. Thank you. As I mentioned earlier on, we have a lot of people online also listening in. And I think even though they have some questions they want to ask, and I think let's put the questions across before we even go to treatment, because otherwise we may forget. We have Vicious Watson. He says that if you take a scan and your uterus is bulky, are you at risk of fibroids then? I hope you understand the question. If you take a scan and your uterus is bulky, are you at risk of fibroids? That's maybe one of you.
Okay, so bulky uterus can mean a lot of things. So, and we've talked about the risk factors for developing uterine fibroids, and I'm sure we didn't mention bulky uterus as one. Okay, a uterus being bulky in a woman can signify early pregnancy. In a woman can mean adenomyosis. In a woman can mean, other things, and fibroid can be one of them. Okay, so just a scan picking up the uterus is bulky doesn't mean that necessarily if we follow you up you develop fibroid. No, that I want to just
All right. So she should just continue to see the gynecologist. Exactly. They will help her to.
Exactly.
Good. Okay. Nad Ade Mankobia. He says that a friend has been diagnosed of fibroids, and the fibroid which has actually filled the whole uterus. And so it has been recommended that she undergoes hysterectomy. And you know, she is not taking it kindly. Do you have any advice?
So thank you. As we go on to management, I must say that we'll be showing some pictures, and these are not pictures from the internet, or these are real pictures of cases we've done here, and some of them will be similar to the story that she's talking about. And I think we must viewer discretion. These are gross pictures, so if you are worried, you know. So this is a common thing. So she's had fibroid diagnosis. As a response, and lots of people, and part of the reason is because a lot of yes. So this they are and I problem of a lot of misconceptions, and I think that is why doing this help break down the myths. So really, once this diagnosis has been made and the doctors have recommended that you need to have whole womb is removed, I'm sure they have gone through different phases and decided that this is the best person together with the patient, and that's why, because that is not the only option, but for her aging, all those things, this is the treatment of choice. But the point is that this is a procedure that is done by us every day. And if I say us, not just us, but other gynecologists across the country. So I say that to mean that they are experienced in doing this. This is not something that our clients should be worried about. In the hands of experienced people, and I know a lot of gynecologists across the country are quite experienced, it is a safe procedure, and the quality of life of this patient will return after they get treatment.
Okay. Yeah, Prof. I just want to add, sometimes we don't know the other, history concerning this. Probably what might have informed why they want to do hysterectomy for her. But I would say that, that being said, there are medications that sometimes we've seen in our clinics, and we've seen women who have come in with very huge fibroids, and though we thought that we couldn't do myomectomy, I'm sure we'll come to that. So we had to take the whole womb away. Now there are medications available that we can give that can reduce, the size of the fibroids. And then when we go into surgery or we go to operate, because you see, it's the fear of the complications that are associated with you wanting to do a fibroid cell or myomectomy. Probably that may have contributed. So I must say that there are medications that can reduce the size so significantly that maybe she may just need that was saying that we don't have the full story, but then maybe they were taking other parameters into consideration before they offered her the hysterectomy. But if all things being equal, she should know that there can be other medicines that are available now that can shrink or reduce the size, that can make it possible for her to have a myomectomy done.
Good. Now, so what Dr. Kumi and Dr. Tete are saying is that they don't have a lot of your history, whether you have even done the surgery before, whether you are 50 years, whether you are not interested in giving birth, and other factors. So maybe one day we can talk about this. There's Na Shika Okain. She's asking a very pertinent question. She wants to find out whether the size of fibroid can actually make pregnancy cryptic. Pregnancy cryptic. Let me put it that can the size of a fibroid make a pregnancy cryptic?
So that's an interesting one. Yes. I don't know, Prof, why you say it's pertinent. This one.
Yeah, because we've had situations where people say you can be pregnant and fibroid is there and you won't see and that kind of thing. I'm sure that's where Na is coming from.
Yeah. Yes. So, so I think let's unpack this, that we have, occasionally we get clients who come in and actually say that they've been pregnant for several years. In fact, as we talk about these stories, my team had a patient, this is about 6 years ago, who was convinced that she's been pregnant for about 5 years. And she was referred to us because pregnancy tests by herself in the hospital where she was referred all showed that it was negative. She did an ultrasound scan, nothing. But she strongly believed that she was pregnant, that she could feel fetal movement and all that. And this is where the cryptic pregnancy come in. In fact, when she came to us, we also, we have to accept the history and go through the investigation and found out that there was nothing. But this patient was so convinced, even about the date of delivery, that it is us, we are the ones not seeing it, that the pregnancy will drop at some point when it's ready to come.
Good.
Now, having fibroids, and this is a real medical condition. So we found a way to deal with the situation, but this is a real medical situation, and when they come, we don't turn them away. But the issue is that when patients have fibroids, as we've said, sometimes not just them, others around them actually say that they are pregnant, and they believe they are pregnant. Now, of course, when the scan is done, what will be found is not a baby. They will find the fibroid. But if this patient has a strong belief that they are pregnant, your ultrasound scan is not the one that is going to convince them. But the truth is that this is a real medical condition that has to be dealt with by a multidisciplinary team, but the evidence doesn't support that the fibroid is replacing the pregnancy and then at some point the baby will show and all that. No. The fibroids, as I said, some people are working in our communities and in fact they are buying baby stuff waiting for the baby, but all we know is that it is fibroid. Thank you.
All right. One or two questions, then we can move on to the treatment. So Ivy Asumeni Bwache said she's had surgery done. Are there any other measures to take to prevent regrowth? She has had surgery done for her fibroids, and she wants to find out from us if there are measures that she can take so that this fibroid will not regrow, because it looks like she's heard that they may regrow.
Yes, thank you, Prof. So, Ivy, thank you for your question, and I'm sure you are concerned about recurrence. Prof, recurrence of fibroids is something that happens, okay? And the variation or the duration with which they would come vary, from one woman to the other. Okay, so we've had surgeries for within a space of less than 6 months, it comes back, or they see the growth as small. When a scan is taken, and then, some can go up to about 2-3 years before they come back. As Dr. Kumi said, and I just want to give her some hope, that you see, he mentioned that some things are protective in the sense that they delay a fibroid coming back or recurring. And one of the things is pregnancy. So if you would, listen to most gynecologists after a fibroid surgery, they would most times advise the women that try and get pregnant, because pregnancy is one of the things that will delay the recurrence of a fibroid coming back. So one of the tips I'll give her is that if she has not considered it, probably she should consider it, because it's one of those things. But aside that, I'm sure she wants to know whether there are, exercises or certain foods or things that would delay its recurrence. That one, no. Okay, so that's what I'll say. I don't know if Dr. Kumi wants to add.
Yeah, it's difficult, as Dr. Tete said. A lot of the studies have mixed results, so it's difficult to pinpoint this, but we know, just maintain a healthy lifestyle is what we advise to everybody, not just for fibroid recurring. But just to add to what he said, it may also never recur. But recurrence is a major risk. What sometimes we tell them, as long as we've not taken the womb out and it's there, you can have a recurrence. As he said, you can't predict. Sometimes it can be quick, sometimes it can be very slow, sometimes it may never have. In fact, evidence that the growth averagely may be just about 0.6 centimeters per year. And we've had situations where we've had surgery, fibroid surgery, we've just removed the fibroid, left the womb intact, and then 3 years down the line, this one get pregnant, we are doing a C-section, and found the womb is clean. We don't find any fibroids. So that too can happen. But as Dr. Tete said, a lot of the time there is that consideration because of the evidence that pregnancy is protective. But of course, that is not to say that go force yourself and conceive when you are not ready. So it's a very difficult thing to say, but we can't predict that yours will recur or it won't recur, and even if it will recur, how fast it will be. Get it done if it's giving you symptoms, and then let's live life.
So one day, I saw a patient who had been seen by someone, had surgery done, and she told me that the doctor said one of the things that the doctors themselves are afraid of most is going to do another surgery for somebody who have had surgery. I'm sure it's related to what she's trying to say. And is that something that we are really, really afraid of? And why?
As clinicians.
As clinicians, as gynecologists, I think.
Yes.
Yeah.
No, so we have our concerns and I'll address that. But the client too have concerns. They know that I'm going to have a second procedure. I'm going to have a third procedure.
They think it's easy.
Already, well, it's a mixture here. Some people, like we've talked about, even the first surgery, they have to gather a lot of courage to come for it. Now she's come for it, she's gone home safe, and she has to come back again. So it's a real challenge. For us, if we take the individual history and examine and find out that surgery is necessary, we are prepared. We have the expertise to do it. We know the potential complications, and knowing it means that we prepare for it. So obviously, it will not be as straightforward as the initial one, but this is why we've studied. This is why we've been practicing for all this while. But for us, the concern is that the patient knows that they are in good hands, and irrespective of the number of times, we are ready to help them if need be.
And the last one is, can fibroid kill? This is from Nashika Perry Kwao.
So to address this, can it kill? That's the question. So when we talk about cause of death, we have direct and indirect. You see, it depends on a lot of things. If a patient has fibroids and dies, the question is it the fibroid that killed the patient? Let's look at some of the things I talked about. About 5 years ago, so this was I was with one of our consultant, Dr. Ntumi, and this patient presented in shock. She had collapsed at home. There's somebody who knew she had fibroid, but because of fear, she had not presented to the hospital. She had collapsed at home. Young woman, everybody thought this woman has a ruptured ectopic. Of course, when we examined her, it looked like she had fluid in the abdomen. We had to rush her like we do for all our emergencies, do surgery for her. We opened her up, and it was a lot of blood. Some of the blood vessels feeding the fibroid had ruptured. Wow. This patient, if had not presented on time and were not, up to the task and sent her in, she could have died. Of course, some people have died from other complications. It may cause even kidney, problem. I know Ghana kidney problem has become an issue. And yes, depending on the size, I'm sure we'll be talking about it, it can compress on the ureters and affect the kidneys. And of course, if that person dies, although the immediate cause may be the renal complications, the initial insult is from the fibroid. So there are different things and all that. Directly, yes, but it depends on the presentation.
All right. So we'll move on to the treatment, but this is a very short question. I just want you to. Okay. That an ultrasound scan revealed fibroid at during my third trimester. This is from Jacqueline Asamoah. But after delivery, when she did a scan, there's no fibroid. Is that possible? She was told she had fibroid when she was pregnant, and after delivery, a scan, the same scan, is saying there's no fibroid. It's the same scan. That's how she put it.
Yeah, so Prof, yes, thank you, Jacqueline, for your question. You know, we know that earlier when we were talking, we said that these fibroids are fed by blood vessels, okay? And once you increase the volumes to the womb or the uterus, and this so happens when you are pregnant. So there's so much supply of blood to the womb. So even a small fibroid that was not detected earlier when she was non-pregnant, you know, once you get pregnant, can become big. And we've seen in several women, you know, sometimes it's very small, tiny fibroid somewhere. She gets pregnant, and then you see. And now 3 things can happen to fibroids when you are pregnant, okay? It may remain the same, it may become big, or might even regress. Okay, so it's possible that that fibroid was very small initially, that wasn't seen. As the pregnancy, you know, went on, or as it developed, maybe 3rd trimester, they saw, I don't know the size. She didn't provide us with the size. Okay, that would have, helped us a lot. Okay, so they saw the size, so probably an ultrasound scan can pick it up. But once you give birth, again, because of the uterus comes back, it involutes. So that fibroid that was seen, because when you're pregnant, a lot more of the hormones we talked about are available to feed those fibroids. So once those hormones are taken away, those fibroids can regress to the size that probably was tiny, and the scan may not pick it up again. All right. Yes, so that's what I'll say.
Is it possible that they also misdiagnose her?
It's also possible. Okay. It's also possible that probably whoever was doing the scan probably saw something that looked like. And that can also be a possibility.
All right. So it's possible, and Prof, sometimes the resolution of the ultrasound machine. Okay, things are improving, and maybe the resolution was, you know, good. The different machine is being used. It may be the same sonographer. It may even be a different sonographer. But there are a lot of reasons why. I think this whole thing is about when I have fibroids, can it eventually vanish or disappear?
Okay. It looks like we have a lot more questions. So let's quickly talk about the treatment. And then, very briefly, then we can talk about the question, because we have a lot of questions. People are really asking more questions. They are excited to hear about some of the information we are giving out there. So please, Dr. Tete, can you tell us about the various modalities?
Yes, so to start with, as we said from the beginning, okay, not every woman that has fibroids would need treatment. Because we said majority of the time, the fibroids don't do anything to the woman. So for that reason, the fact that you have fibroids doesn't mean necessarily we have to put you on medications. So now we say that those that are symptomatic, so those that will bring a woman or give a woman worries, okay, that will bring the patient or the woman to the hospital, would warrant that we do something about it. And we've talked about the main symptoms, being abnormal uterine bleeds, being pain, being bulk symptoms or obstructive symptoms, and then issues about reproductive dysfunction. So, and when we take these, you know, so the treatment is tailored to solve these 4 that I've mentioned, I've talked about. And there are a lot of, you know, options, treatment options. And it again depends on the age of the woman, the reproductive wishes of the woman, okay, and then sometimes, you know, the experience of whichever clinician is taking care of, and the ability to do certain procedures or not. So if we take, let's say, for those, I'm sure majority of them will come in with abnormal uterine bleeds, okay? A bleeding that is worrying her, that's affecting her quality of life, that she's not able to do anything. So for those ones, first of all, the modalities would have is, we have medical, okay? So if I say medical, these are medications we can give, you know, in emergency situations to stop the bleeding, okay? So that the woman can, you know, have some quality of life and then can build up. Because sometimes what we didn't mention about is one of the ways they can present is anemia, okay, be it chronic or acute. So some can, because of, you know, bleeding excessively during her menses, can present, the woman can come in with anemia. So we try to give these medications to stop the bleed so that she can build up on her hemoglobin levels and then stop, because we know anemia can predispose them to other, you know, morbidity or other problems that are associated with women who have anemia. So that's medicine. And then we'll have, aside the medication, so the medications, we have some that we give orally, okay, some that we can give transdermal, and these ones are basically hormonal in nature, okay. There are some that we can give transvaginal, through devices and all that, okay, to limit the bleed. So from there, we also have other interventions, okay, where we can put in certain particles, okay, under ultrasound guide, okay, or what we say the radiological intervention, where we go to the umbilical artery, and then, the uterine artery, and then we embolize it, okay. That will stop bleeding. So those are medical options. And then the other is the non-medical. So the non-medical is where you would have surgical intervention, okay. So the fibroid, we talked about not necessarily the size, but the location. So if you have a submucous fibroid where we have to go in and take out the fibroid to stop the bleeding. So sometimes it's not always the case that we have to go through the abdomen. Sometimes we go through the vagina into the uterus through a camera, okay? And we can take out those notorious fibroids that causes bleed, okay? That's surgical interventions. So the surgical options, we have two main. If you want to preserve your fertility, if you don't want to. So if you want to preserve, basically what we do is myomectomy, and there are various types. I'm sure I will throw more light. And then if you don't want to preserve the uterus, or if you don't have the desire to have children again, we'll have the hysterectomy, where we take the whole womb out. I'm sure we'll have pictures that we can show. So, and then the last I would say is that last of the treatment is, and I'm happy to say this because you see, in the clinics, most women shy away or fear because of the option of surgery. Okay, where people think that once you have fibroids, then we have to do operation for you to take them out. But recently, there have been new technology or new innovations about how we're using, high-intensity ultrasound, focused ultrasound surgeries, to try and effect these fibroids that you don't need to be cut. And that's where we are moving to. Okay. Unfortunately, we don't have it here in Ghana, but elsewhere, yes, they have it. And I'm sure that's some good news for our women who are afraid, to have, surgeries for fibroids. All right. Yeah, so that's the broad. I don't know, Dr. If you want to throw more light.
Yes, I think that's the main thing. But the point is that not all women who present with fibroids will require treatment. For some, the management is reassurance and probably
observation.
Yes, reassurance and observation, like you said. So, and interestingly, most of the women who fall into this category are those who, found out that they had fibroid incidentally. They don't have any issue, but maybe because they were going to be investigated for something else. They are going to school, they are going for employment, and part of their investigation, they do an ultrasound, find out. They come, we only reassure such patients. Now, those that require treatment are those that are having problematic fibroid that are giving them problems. And as we will show in a lot of the pictures that we have, we will appreciate that, and I'm sure some of our clients listening to us and watching us would attest to the fact that oftentimes when they come to us, in fact, we don't talk about the medications. We talk about the surgeries. And the reason is because of the state in which they come. They already come with fibroid that are extremely huge because, let us be clear, they can be single. You can have a single fibroid. You can have multiple, and mostly they are multiple. So most of the patients we are seeing, because of the things we've talked about, being fearful of surgery, they may only present when it's like all things are failing. So by the time they come, most gynecologists will not be talking about medications. And as we talk about the medication, let's be clear, they are only temporal. They are only dealing with the symptoms that he talked about. So eventually, those who are put on medication will eventually require surgery.
Okay.
So if you look at the picture that on the screen, for instance, this woman comes, it will be difficult to say, okay, I'm reassuring you, or you are just taking medication. Because this patient came and her main problem was the fact that her tummy has become big, and she was also having ready for the procedure. You won't come one day and then we carry you to theater. That will even heighten the complications the more. So when you come, to minimize the complications, we go through a lot, and maybe at some point we'll talk about it, but the point is that there can be complications. Even from giving you the anesthesia that will make you pain-free during the procedure, you can have complications from there. You can have complications from the procedure itself. Immediately after the procedure, you may have complications, but we talk to the patients not to scare them away. We let them know the successes that we have. Okay, because over the past 1 year, we've had a lot of these procedures, and the complications are less than 1%. Okay. So the key thing is that we discuss all these things with them, and then they make the choice of treatment.
Yeah, so Prof, Dr. Kubi, having said that, we have to let them know. So it's a major surgery, so early complications, intra-op complications can be bleeding. Yeah. And most times, because I'm sure one listener asked about the doctors telling her that she would have hysterectomy instead of myomectomy. And I'm sure one of the considerations is because of bleeding, intra-op. So bleeding is one of the common complications when you are doing a fibroid surgery. And if you don't optimize the patient well, you don't prepare the patient well, you are not ready, because it is real, it can happen whilst you are in surgery. So you make sure you have, standby blood. That's when you need, you can call upon and give. And there are just times that we do surgeries that we know in the course of the surgery, the anesthetist would have to go and bring blood and set it up for the patient because the patient is bleeding. Although most times we try to, use a tourniquet, okay, to try and reduce the blood loss at myomectomy. But yet, sometimes because of the huge nature of some of the myomectomies we do here, they bleed. So bleeding is one. And then one of the other things is that damage to adjacent organs. I told you the womb is, sandwiched by the bladder and the rectum. And sometimes the huge nature and the very long-standing nature of most of the fibroids we see, you see them having attachments of bowel, of bladder, to the surfaces of the womb. And those ones can be injured during the surgery. Okay, so, these are some. And then post-op, there can be, infections, and then depending on, who did it, like Dr. Kumi said, if whoever is doing doesn't know, sometimes, if the antibiotic cover is not well, and that some can even become necrotic. All right. Okay, and the patient can lose the womb. And these are some of the complications, real complications that can happen.
Yeah, but I think with all these complications, you are prepared. There are ways to solve those complications if they occur. Yeah. And as he said, in experienced hands, you don't really get some of these complications. Very good. Let me read some of the comments given and maybe some of the questions. This time, maybe we are getting to the end, so we need very brief answers. Naomi Opon says that I'm really enjoying the program, and Unison said it's very educative. Elizabeth wants to know something about what adnexal fibroid or leiomyoma is. Please, what is adnexal leiomyoma or fibroid?
I think, as you said, because of time, we'll make it
so
brief. So when we showed a picture of the womb.
Can you show?
So the womb has a front, a back, and then the sides. So just to explain, the sides are just in simple terms, the side of the womb is the adnexal.
Okay.
And you may find fibroids on the side.
Okay.
So remember, you have the front, you have the back, you have the left and right side. If you have fibroids located on the side, left or right, people may describe it as such. So,
good. There's a very important question here, and I think you mentioned it earlier on. Can it be cancerous? Can it be? This is a complicated question. Even though you mentioned that they are benign, but she's asking whether they can be cancerous.
Yes, so thank you, Prof. So thank you for the question. Fibroids mainly, when we started, we said that they are benign, non-cancerous growth or tumors. But less than 1%, sometimes they become cancer. Okay, and we've had cases that have come in that people thought, or even at surgery, we thought that we were going to do a myomectomy, only for you to go in and see a leiomyosarcoma. Yeah. Okay, so yes, it can become cancerous. So, but they are not very rare, very rare. Yeah, less than a percentage.
All right. Then Abigail wants to find out, Abigail Koko or say, after going through the surgery, will the heavy menses stop? That's what she wants to find out. Will the heavy menstrual flow, will it stop? Will it stop after going through the surgery?
So as we said, if the fibroids are causing symptoms, and for in this particular case, maybe the reason for the fibroid
surgery
operation, and let's remember the fibroid operation in this case is that we are removing just the fibroids and leaving the womb, which is the myomectomy.
Yeah.
If that the reason was because of the heavy menstrual bleeding, it should stop.
Yeah.
Because as we've talked about, the location of the fibroid in her case may be that it is in the cavity, what we call the submucosal ones. And when we go in for such patient, we would remove those fibroids. In fact, remember, oftentimes when we go into surgery, the question often for people is, do we have to even enter the cavity? If the reason for operating on that patient is because of heavy menstrual bleeding and the ultrasound scan done has mapped out the fibroids, we know the locations, we will remove all those nodules. And it is expected that the heavy menstrual bleeding should stop. So definitely that is the outcome that we desire in our surgery. And most of the time, the symptoms actually go because the surgery removes the source of the bleeding.
So after my surgery, I don't get, I think she said she didn't get pregnant, but I don't get pregnant again. Secondly, I feel pain in my right abdomen, and it's hard. She wants to find out what is happening to her.
So that is to buttress the point we talked about earlier. Fibroids are not, by and large, the cause of infertility. There may be several reasons, from inadequate regular intercourse, to male factor, to a host of things. So going to remove the fibroids alone may not be there. There may be other things. So that should be looked at.
Okay.
Whatever she's feeling there, I think that it will be better she goes for,
And it depends on the year. As she says, she hasn't been pregnant, and it's sometimes looks like there may be a recurrent fibroid.
Yes.
Yeah, so that's one. But the fibroid surgery itself, going through surgery itself, can it be a risk factor for her not getting pregnant after ruling out all other causes?
Yes, Prof. So thank you. So yes, so the fibroid surgery, we as surgeons go in with a good intention of going to remove the fibroids so that we can restore, the architecture of the womb. But this also comes with adhesions. Yes, so, and depending on how, and for us, in our part, most times the fibroids that we encounter or we deal with are very big and huge. And these ones will definitely leave behind, a lot of adhesions. And these adhesions may be a reason, so they can cause, tubal blockage and all that. And that can affect a woman's ability to get pregnant. Or even inadvertently in the surgery, sometimes where the fibroids are located, trying to take them out sometimes can damage, the openings into the tube.
All right.
And that can also.
So we will be finishing or closing very soon, but let's still try and go through some 2 or 3 more questions, and then we can go. So Abigail wants to find out. Okay, that is the one that can drinking. That is from Nana Opon Gideon. Can drinking alcohol and smoking make you at risk of getting fibroid, and why? This one should be very short.
Yes, I think part of the risk factors we talked about was, I mentioned smoking. And there is evidence to show that actually smoking is protective. And it is protective because it actually reduces the female hormones, and therefore feeding of these fibroids is, but this is not, the complications of smoking are so enormous that
you don't want to.
It is not a recommendation that, it reduces fibroids, so let's have a smoke. Okay, and yeah, so smoking definitely.
But alcohol is identified as one of the risk factors for uterine fibrosis.
So what's the cause of regrowth of fibroid after surgery, and what to do to avoid the surgery?
Prof, I think we've answered this question.
Yeah, you've answered the question. Okay, then let's go to some other questions that I think some of the misconceptions that people may want to, as we wait for them. Is fibroid only common in older women? I think some people think that it's only older women. I have had a situation where we've done fibroid surgery for a university student at 18, 19 years. I don't know your experiences. Have you had a chance where, or seen a case at that very early age?
No. So I think we've been quite clear about the fact that this is actually a disease of women of reproductive age. It is rare to find it in pre-pubertal women, and then for women in their menopause who didn't have fibroids, it is actually difficult to find fibroids. Yes, so reproductive age, because of the fact that it is driven by these gonadal steroids, these hormones, we know that it happens in the reproductive. And the reproductive is a wide age group, from 15 to 49. It is something that,
so kind of
yes, if we find it in somebody in their 50s, it's probably that it was there, and then, so yes.
This question we have answered before, but let me put it. Fibroids always cause noticeable symptoms?
No, the answer is no.
Okay.
Because we said that some can be asymptomatic.
Okay.
Yeah, most of
and then we also talked extensively about fibroid and infertility. So that is something that we have discussed. We are saying that it's not all the time. You have to look at other factors as well. Surgery is the only treatment. Is it true for fibroids?
No. I'm sure when we talked about the treatment, we mentioned the various options that are available for our women. So surgery is not the only option.
Okay. Yeah. So, Prof, as I think, I mean, it's true, surgery is not the only option. And even with the surgery, we have minimally invasive procedures. And in Ghana, it's going on. We have people who have laparoscopic, procedures, which, I mean, the public will know as pinhole procedures, because sometimes people are worried about the big cut they are going to get. Most of the procedures we do here, they will have a nice bikini, incision that is not obvious. But of course, sometimes, if you look at what Dr. Tete did just 2 days ago, okay, as you can see.
Is this from one person?
Yes, this is from one person. So huge that
multiple.
The pinhole procedure and things may not be optimal for such a patient. Yeah. Exactly. So medications may be used, like we say, as a temporary measure just to, build up the hemoglobin, and it probably sometimes shrink it a bit, but ultimately surgery may be done. So it's also influenced by when the patient presents.
Okay.
So surgery definitely is not the only option. And even within the surgery, you have minimally invasive procedures that can be done.
I have two controversial questions. One of them is lifestyle changes don't help. Lifestyle changes. What do you say? This is quite not straightforward. Lifestyle changes, they don't help in terms of preventing fibroids. Is it true?
Okay, so I think that when we talk about the risk factors, we're quite clear that some lifestyle things are
so it's very
influential. Yes, but you see, it's not taken in isolation. Okay, because for somebody who has the genetic predisposition, we've talked about familial and all that, yeah, it may delay the onset, but they may eventually have it. It may be that they may not have it growing aggressively, and so definitely lifestyle modification is good general health practice. But as to whether that alone is going to, prevent you from having fibroids, it's in doubt. And let's know, some people may never develop fibroids. So I think that's
okay. The last controversial one is, I'm sure if we don't answer this question, we don't ask this question, online people will ask us. We have all heard that sometimes they say fibroid actually melts, and it will melt and it will pass down and all that. What do we say about this? We need to answer this question before we leave. We are just at the end of the
so Prof, thank you for asking this question. And I'm sure most of us, as clinicians, are faced with this question all the time. That, especially for women who are gone to other, treatment or other places for treatment, okay, come and ask you that, yes, doc, I've been told that the medications I was given is to melt the fibroid. So whatever is coming out is the fibroid that is melting and showing. We want to state here now that fibroids, as we've seen, I mean, you can see from the pictures, these are very firm, these are very rubbery, and by the way it is their nature, they in themselves don't melt, regardless of the medication you take. So if somebody gives you medication that, oh, take this, and that whatever bleeding you are seeing means that the fibroid has dissolved more or less and it is coming, it is untrue. However, we know that under certain circumstances where we call degeneration, fibroids can change their form from one form, so being firm, rubbery nature, to something that is cystic, okay, and soft. And we say that it has undergone degenerative change. And that can happen. But that one happens and it is in the body of the womb. Okay, so we say that the fibroid has degenerated. It has changed from one form to another. So if you say in that strict sense of degeneration, yes, it can change from that firm to a cystic or a liquid form.
All right.
But that if you take medicine for it to dissolve and come and you see it as your menses, the answer is no.
All right. Have you heard that sometimes they say that if you don't have your menses,
you are getting fibroid?
Yeah.
Yes.
Once you don't bleed for some time, it can lead to fibroid formation. I'm sure it's something that a lot of people, I have heard it several times. And so what do we say? We need to tell them what we think.
Yeah, so this is what we know. And this is an important intervention you brought in because although we've said that the exact cause is not known, people are still looking for the cause.
Yeah.
And as researchers are looking, our clients who are looking for the cause, and it is very easy for us to, find a reason for it. And yes, people think that if your menses is not coming, the blood is backing up somewhere and turning to fibroid. In fact, even for patients whose menses come, but it's scanty, they think that no, it should come a lot because if it's not coming, as they know it to be, then it means that it's accumulating to form fibroid. Please, the menses shouldn't be heavy. If it's heavy, it's abnormal. Now, if the menses doesn't come, there is no blood anywhere to come. So there is no blood to go and form anything. If there is blood in the lining of the womb, it will come out. If it doesn't come out, there is no blood for it to change into fibroid. So that misconception, we hope, will go out there. If your menses is not coming, is it because of pregnancy? Is it because there are many reasons why? But definitely there's no blood anywhere to be backing up to form.
I think one day we will have the webinar on menses and all those abnormalities. I think we are getting close to the end, but if we can give one opportunity for people here, if they have one question, or then we close. All right, good. Can you give us your closing remarks, something that you want people to know, so that as they go, take home messages, very concise ones. Who will start? Okay, take home messages.
All right, so we are really grateful for the opportunity to be part of this educational session, and we hope that the message has gone down. This is a common condition, and unfortunately, our women are mostly impacted by it. It is sometimes unfortunate that the presentation is so delayed, and because of that, we have to, do sometimes radical surgery. There are patients who sometimes really, they have not given birth before, but the presentation is such that we must even remove the entire womb. This webinar, I hope, has demystified the whole thing about fibroid. It is also to say that we are available. The doors of the hospital, are open. People should come, and they should believe that we have experts in Korle Bu, and I think across the country, who can deal with them. If our clients want to take any medications, I think that they should know whether it is FDA approved or not, but definitely your doctors are well equipped, they are knowledgeable, they can manage the condition and any complication that are associated with this. Thank you.
All right, Dr. Tete.
Yeah, so Prof, I would like to take the opportunity to thank all our listeners and viewers for spending their time, quality time, to listen to us. And as Dr. Kumi has said, fibroids are common. And the take home is that once you have fibroids, just know that if you sample 10 women, at least 7 of them, if they are black women, will have fibroids. So don't be afraid. if it's giving you problems, yes, come to the hospital. We are available, and we will help you, to improve the quality of life that you will have. So that's what I will say. Thank you.
Good. Thank you. We want to take a big opportunity to say thank you to our young, enthusiastic, as you can see, very knowledgeable consultants at the Kolebu Teaching Hospital who have taken their time and shared their knowledge, their experiences, and everything about fibroid with us. And we also want to say a big thank you. We appreciate what Kolebu has done for us, giving us opportunity to showcase what we have learned over the years, and also to share all this information with our audience, those online, those around. And also, we thank our colleagues who are still here in the room, waited the whole day to be with us, to still contribute and support us. And all the other people who are here, our cameramen, our people online and all that, we appreciate your time, and we hope that we will continue to educate our friends and our mothers, our sisters, even the men. Online, as we saw some men who were so passionate and even asked questions. We appreciate all your time and the questions you asked. We believe that this webinar has provided a comprehensive overview and discussions on fibroids, and you have heard a lot of stories. And with all this, we will just say a big thank you to our department, also the Department of Obs and Gynae, for giving us or selecting us to lead this course. Thank you very much, and have a wonderful evening. Thank you.
Situation be a me commune na e ha adwen kakra. Me benya fibroid. Na me mpese megedi because me da warf so. Inti na me nim say warfarin, because of warfarin no fibroid into me here me.
For the fibroid cases that we see, the main treatment we offer here is basically surgery.
So the services that we render here, because we have all the professionals here, every referral that is above those at the district, the regional, they all come here.
Yeah, fifi mu ano na yampa se menya fibroid. E na me ba me doctor awo cardio or refer me e ma me ba gynae ha. Ti gynae for so start hwe me. E ko ba say meye surgery, omo be ye me surgery foforo. Na me say we die. Man kan kire obi aba me kan o mitirim se me mba. E na me sign ko me ko share mu sa, but edu baby no na me ntumi biu. E na me ba me san ba biom no na me san ye labs foforo ne nioma bebre ba ni nyina echi no ya ye surgery na ma me aboni bi antome me nam ha aboni bi antome na me nim se ade ne ye kese pa nti na me nim se ehu nti me ntumi nye but nyankopon adom erade fa doctors ne so edije me.
If the woman has fibroid and it's not causing any problem, we leave it alone. If the fibroid is causing a lot of bleeding, such that they have to be transfused and all that, we need to do surgery and remove them. So we have two fibroid surgeries we do basically. What we call the myomectomy and then hysterectomy. Myomectomy is for those who have not yet completed their families. Maybe the younger people, we just go to theater and remove the fibroids singly, and then we repair the womb. For those who have completed their families, we prefer to remove the whole womb together with the fibroids. That's what we call hysterectomy. So for the treatment for fibroid, the mainstay, I'll say, is surgery. Those that have no symptoms at all, we just reassure them. It's not every fibroid that comes down, we quickly go and do surgery. No. A lot of them that are not causing any problem, we just reassure the clients that they should, we do what we call watchful waiting. It's when they are causing symptoms that we should go and do surgery for.
First, no, you bokole goodin na me yam hyehyeme. Yes, ebi mu say enye.
is so small when we take it. Is so small when we pick it early, but the cost of treatment is so huge if we pick it late, and even that the treatment is not